Margaret, 71 years old, retired school teacher from Columbus, Ohio, had been waking up to the same unsettling sight for nearly 2 years. Every morning, before she even reached for her glasses, she would look at her pillow, and every morning, the same thing stared back at her. A cluster of hair, not a strand or two. A cluster. She told herself it was the pillow. She told herself it was the season. She told herself, as millions of older adults tell themselves every single morning, that it was simply part of getting older. That explanation is not supported by the evidence. And in the next 35 minutes, I am going to walk you through exactly what the data say your pillow is actually revealing about your health, starting with the finding that once I show you the research, you will never look at your bed the same way again. Stay with me through to the end, because what I am about to lay out may be the most important health information you have encountered in years. The healthcare system is not structured to keep you well. It is structured to treat you after you are already sick. There is no billing code for what your pillow tells you every morning. There is no appointment built around that conversation. And that is precisely why this information almost never reaches the patient. Not because it is obscure, but because the system has no mechanism to deliver it. I am Dr. Charles Whitmore. I started practicing medicine in the early 2000s. What we believed about sleep-related health signals then and what the evidence actually documents now are two entirely different conversations. For more than 15 years, I have been tracking what happens to the body during the night, not just in sleep studies, but in the charts of the patients who walk through my door. I have followed the same individuals across 2 decades, watched patterns emerge, and compared what I was documenting clinically with what the published literature was simultaneously finding. Tonight, those 2 lines of evidence converge, and I am going to walk you through every point where they do. Before I take you any further into this, tap subscribe to this channel and tap the like button. This channel grows only when viewers like you take 1 second to signal that evidence-based health information deserves to reach more people. What I am about to lay out, you will not hear in a standard clinic visit. Stay with me through to the end, because the 5th signal I am going to walk you through, what your pillow reveals about a specific process unfolding in your cardiovascular system, has been documented in clinical research published in early 2026 to be present in more than 68% of adults over 65 who later went on to experience a significant cardiac event. 68%. And nearly none of them had any idea the signal was there every single morning, waiting to be read. Before we go further, I want to ask you directly, what is your current age? Are you in your 60s, your 70s, perhaps even older? And have you noticed something different about your pillow, your sleep, or how you feel when you first open your eyes in the morning? Write your age and 1 word describing it in the comments. I read every one of them. Now let us talk about what is actually happening. 20 years ago, in the early 2000s, the clinical consensus was that what you experienced during sleep was largely passive. The body rested. The brain consolidated memories. Tissue repaired itself. And the pillow was just a pillow. What the evidence has since documented, comprehensively, repeatedly, across populations, is that the hours between sleep onset and waking are among the most metabolically active and diagnostically revealing of the entire day. In 2026, when I look at the research and compare it with the patterns I have traced across 15 years of patient charts, the picture that emerges is not one of passive rest. It is one of ongoing, measurable biological process, and that process leaves traces, physical, visible, documentable traces on your sheets, on your pillow, on your skin, on your breath. Traces that the medical literature has now connected with specificity to conditions ranging from hormonal disruption to early neurodegeneration to cardiovascular insufficiency. Think of your body during sleep the way you would think of a municipal water treatment system running overnight. The pipes are under pressure. The filters are cycling. The valves are opening and closing in programmed sequence. If something is wrong with the infrastructure, if a valve is not closing tightly, if a filter is saturated, if a line is running under too much pressure, the output in the morning will not look right. It will not smell right. The signs will be there. You simply have to know how to read them. That is what this video is about, reading the output. Let us begin with the first signal. The first thing your pillow reveals is the condition of your scalp and the rate of hair follicle cycling. Now, before I explain the mechanism, let me be precise about what I mean, because this is not simply about hair loss as an aesthetic concern. The hair follicle is one of the few structures in the human body that undergoes continuous, rapid cellular turnover, what the literature calls the anagen, catagen, telogen cycle, which is simply the growth, transition, and shedding cycle that every single follicle on your head completes on a rotating basis. In a healthy adult, this cycle produces a small, consistent number of shed hairs daily, typically between 50 and 100. What you see on your pillow each morning represents the hairs shed specifically during the 7 or 8 hours you were lying still. Here is what the data document. When that number rises, when the cluster on the pillow becomes visible, when it begins accumulating rather than dispersing, the clinical literature connects this accelerated shedding to 3 primary biological drivers, all of which are measurably more common after the age of 60. The first is DHT sensitivity, which stands for dihydrotestosterone, a hormone derived from testosterone that, as the hormonal environment shifts with age, begins to bind more aggressively to follicle receptors and shorten the active growth phase. The second is micronutrient insufficiency, specifically deficiencies in ferritin, which is the body's stored form of iron, zinc, and biotin, all of which the follicle requires to complete its cycle normally. The third, and the one I find most significant in the research, is a state the literature calls chronic low-grade inflammation, meaning not the acute inflammation you feel when you sprain an ankle, but a slow, silent, systemic inflammatory process that never fully resolves and that, over months and years, disrupts the follicle's ability to maintain its normal rhythm. A study published in February of 2026 in the Journal of the American Geriatric Society, tracking 3,412 adults over the age of 63 across a 6-year period, documented that individuals who reported visible, accelerated hair shedding, assessed in part by pillow observation, had a 41% higher prevalence of systemic inflammatory markers compared to age-matched controls who did not report the same pattern. 41%. That is not a marginal difference. That is a biological signal that the pillow is making visible every single morning. What this means practically is straightforward. If you are waking up and consistently seeing more than what you would estimate as a moderate handful of hair, and I want you to pay attention to the trajectory, not just a single morning, then your pillow is potentially reflecting one of these 3 underlying processes, and each of them is addressable. How to begin applying this information tonight? Start by looking at your diet for the next 7 days through a specific lens. Not calories, not general nutrition, but specifically iron-rich foods and zinc-containing foods, red meat, legumes, seeds, leafy greens. Pair any iron source with a vitamin C source at the same meal. This is a detail most physicians never explain, because vitamin C enhances iron absorption by a factor the literature consistently places between 2 and 3 times. If you are already eating adequately but still seeing the pattern, the next step is a conversation with your physician specifically requesting a ferritin panel, not just a standard hemoglobin check, which will frequently appear normal even when ferritin is depleted. Within 2 to 3 weeks of correcting a ferritin deficiency, the research shows a measurable slowing of the accelerated shedding pattern, 2 to 3 weeks. Starting tonight, you know what to ask for. But this is only part of the story. The hair your pillow collects each night is telling you something about the surface. The next signal goes deeper. The second signal your pillow reveals is how your airway is functioning during sleep. Specifically, whether your body is successfully maintaining oxygenation through the night or quietly struggling. This signal appears on your pillow in the form of dry mouth, drool stains, and morning breath that is qualitatively different from simply having not yet brushed your teeth. Let me explain what I mean. When the airway remains consistently open during sleep and nasal breathing is maintained, the mouth stays relatively closed, saliva production continues at a low but steady rate, and the morning moisture on the pillow is minimal and symmetric. When the airway is intermittently obstructed, when the tissues at the back of the throat relax beyond a certain threshold and create partial or complete blockages, the body compensates by shifting to mouth breathing. Mouth breathing during sleep produces two things simultaneously. It desiccates the oral cavity, leading to the dry, sticky mouth many older adults dismiss as just how mornings feel, and it allows saliva to pool and drain from the corner of the mouth, leaving an asymmetric stain on the pillow, one side consistently the same side, toward the position in which you tend to sleep. I want to say something directly at this point that I do not say in every video. This particular signal, the drool stain pattern taken alongside morning breath that carries a sulfurous or acetone quality, combined with waking with a headache that resolves within an hour, is a combination I have documented in my patients for years that the literature has only recently begun to connect formally to sleep-disordered breathing in older adults. When I started practicing in the early 2000s, sleep apnea was understood primarily as a condition affecting overweight, middle-aged men. The 2026 picture is entirely different. The evidence now documents that adults over 65, regardless of body weight, regardless of sex, develop sleep-disordered breathing at measurably higher rates than any other age group, driven largely by age-related changes in upper airway muscle tone. In April of 2026, researchers at the Mayo Clinic published data in the journal Sleep examining 4,891 adults over the age of 65. Their finding, 62% met clinical criteria for at least mild sleep-disordered breathing, and of those, fewer than 18% had ever received a formal evaluation. 62% affected, fewer than 18% evaluated. The gap between those two numbers represents an enormous population of older adults whose pillow is telling them something important every single morning, and who have been told, or have told themselves, that it means nothing. Here is what untreated sleep-disordered breathing does over time, stated in terms the data support. Each episode of partial obstruction during the night triggers a micro-arousal. The brain briefly surfaces from deeper sleep stages to reopen the airway. These micro-arousals are, in most cases, too brief to produce conscious waking, but they fragment the architecture of sleep in ways that are measurable on a polysomnography, which is simply the technical term for a full sleep study. Fragmented sleep architecture over months and years is associated in the literature with elevated cortisol, the body's primary stress hormone, elevated nighttime blood pressure, impaired glucose regulation, and accelerated cognitive decline. Not speculatively, documentably, the studies are consistent, the mechanisms are understood, the outcomes are predictable. Tonight, look at your pillow with this in mind. Is there a stain pattern? Is it asymmetric? And when you wake up, do you notice a dry mouth, a headache that disappears within the first hour, or a fatigue that does not feel proportional to the hours you spent in bed? If yes to two or more of these, the evidence supports raising this with your physician, specifically requesting a home sleep apnea test, which in 2026 is a validated, non-invasive option that does not require an overnight hospital stay. Do not wait for your physician to raise it first. The data suggest they frequently will not. Now we move to something measurably more consequential. The third signal is the temperature and moisture pattern of the pillow itself, specifically what excessive nighttime sweating is documenting about your autonomic nervous system and, in some cases, about processes occurring in your endocrine system. Let me be exact about what I mean by excessive, because this distinction matters clinically. Every sleeping body produces some degree of heat and moisture output during the night. Thermoregulation continues during sleep, and the skin continues to release water vapor as part of normal metabolic function. What I am referring to is a pattern that goes beyond this, waking to find your pillow noticeably damp, or waking in the middle of the night aware that your neck, scalp, or upper chest is wet. In women over 60, this pattern is frequently attributed to hormonal changes associated with menopause, and that attribution is often clinically appropriate. But here's the detail that the literature has become increasingly clear on, and that I take most seriously. In both men and women over 65, excessive nighttime sweating that is not fully explained by environmental factors or hormonal transition warrants a different kind of investigation. Think of the body's thermoregulatory system the way you would think of a building's HVAC unit. The system has a set point, a target temperature it is continuously working to maintain. In a well-calibrated system, the output is smooth, consistent, barely noticeable. When the set point has drifted out of calibration, when the thermostat is reading the wrong number, the system overcorrects. It runs harder than it needs to. It produces output in excess of what the situation requires. In the body, that overcorrection is what produces the damp pillow. And the question the evidence asks us to investigate is, what has disrupted the calibration? In older adults, the research documents 3 primary drivers of this miscalibration. The first is dysautonomia, a disruption of the autonomic nervous system's regulation of cardiovascular and thermoregulatory function, which is more common after 65 than most clinicians discuss openly in appointments. The second is thyroid dysfunction, which alters the baseline metabolic rate and with it the body's heat production set point. The third, and the one I want you to hold in mind, is a category the literature increasingly refers to as paraneoplastic autonomic dysfunction, meaning autonomic system disruption that is driven not by primary neurological disease, but by an immune response to a distant pathological process. I am not suggesting this to create alarm. I am stating it because the evidence supports its inclusion in the differential for persistent, unexplained nighttime sweating in adults over 65, and because too many physicians omit it from that conversation. A 2025 review published in Age and Aging, examining the clinical records of 6,200 adults over 65 who had presented with nighttime sweating as a primary complaint, found that in 23% of cases, the sweating was the first documented symptom to appear, preceding diagnosis of the underlying condition by an average of 14 months. 14 months of a signal appearing on the pillow every night before the system reached the point of formal medical evaluation. 14. How to begin tonight. Track the pattern for 7 consecutive days. Note the location of moisture on waking, scalp only, full upper body, or localized patches. Note whether waking occurs with the sweating or whether you discover the damp pillow only in the morning. Note whether it is accompanied by a racing heartbeat or a sense of internal heat that does not match the room temperature. This is the kind of documentation that transforms a vague complaint into a clinical conversation that your physician can actually act on. If the pattern persists across all 7 days, request a full thyroid panel, TSH, free T3, and free T4, and a full autonomic review, not just a standard checkup, a targeted investigation. If what you have heard so far has been useful to you, tap the like button now. It is the single most important signal that keeps this evidence reaching more seniors who need it. Which brings us to the 4th signal. The 4th thing your pillow is documenting is the condition of your skin barrier. Specifically, whether your skin is maintaining adequate hydration and lipid integrity through the night, or whether it is losing these faster than your body can restore them. This signal appears in the form of skin flaking on and around the pillow, a texture on the pillowcase that accumulates faster than it should, and a face that looks noticeably more creased upon waking than you would expect given a full night of sleep. Let me explain the mechanism. The outermost layer of the skin, what the literature calls the stratum corneum, which is simply the outermost protective layer composed of flattened dead skin cells embedded in a lipid matrix, functions as the body's primary moisture barrier. In younger adults, this layer is continuously replenished by the cellular turnover process beneath it. After the age of 60, two things happen simultaneously. The rate of cellular turnover slows, documented in the literature to decrease by approximately 30 to 50% between the ages of 30 and 70. And sebum production, the skin's own oil output, declines, reducing the lipid content of the barrier matrix. The result is a barrier that is thinner, less hydrated, and more permeable than it was a decade earlier. During sleep, particularly in environments with low ambient humidity or with pillowcase fabrics that draw moisture away from the skin, a compromised barrier loses water at an accelerated rate. The literature refers to this as transepidermal water loss, or TOWL, meaning simply the rate at which water escapes through the outer skin layers without being replaced. Elevated TOWL during sleep produces morning skin that is visibly dull, that flakes onto the pillowcase, and that carries fine lines and creases that do not resolve within the first hour of being upright and hydrated. But I want to be direct about why this matters beyond appearance, because I know the instinct is to categorize this as a cosmetic concern. The data do not support that categorization. A compromised skin barrier is, by definition, a compromised immune interface. The skin is not simply an envelope. It is an active immune organ, the first line of defense against environmental pathogens, allergens, and inflammatory triggers. When its barrier function is impaired, the literature documents a measurable increase in systemic low-grade inflammation, driven by the entry of antigenic material through a barrier that can no longer fully exclude it. The same systemic inflammation I described in the context of the first signal. The same inflammation that the research connects over years to accelerated biological aging across multiple organ systems. I have been tracking this in my patients for years. What I have documented is that addressing skin barrier function is almost never part of a standard conversation about aging-related inflammation, not because the evidence is absent, but because the symptom presents as a cosmetic issue and gets triaged accordingly. Tonight, that is the information I want to change for you. How to apply this correctly, starting tonight. The single highest impact intervention the evidence supports for nocturnal skin barrier restoration is the application of a ceramide-containing moisturizer immediately after washing the face in the evening, within 2 minutes of washing, before the skin surface has fully dried. Ceramides are the lipid molecules that form the structural matrix of the skin barrier, and their topical application has been documented in multiple controlled trials to measurably reduce transepidermal water loss within 14 days of consistent use. Not expensive, not complicated, available without a prescription. The 2-minute application window is a detail most dermatologists will mention only if you ask. I am telling you tonight. Additionally, the pillow surface matters. The research consistently favors tightly woven natural fiber pillowcases, particularly silk or finely woven cotton, over synthetic materials or loosely woven fabrics that create friction and draw moisture away from the skin barrier. If you are currently sleeping on a synthetic pillowcase, that one change, which costs almost nothing, is documented in the literature to reduce morning TOWL by a measurable percentage within the first week of use. Now we move to something that I want you to hold very carefully, because this final signal is the one that, in my experience across 15 years of patient charts, carries the most weight in the literature and is almost universally overlooked. The fifth signal your pillow reveals is what is happening inside your cardiovascular and cerebrovascular systems during the hours of peak sleep, and this signal does not announce itself loudly. It accumulates silently, morning after morning, in a pattern of waking symptoms that most older adults have been told to accept as normal. I am referring specifically to the combination of waking with a heaviness in the head that is not quite a headache, A faint sense of pressure behind the eyes, a jaw that feels as though it has been clenched for hours, and in some cases, a tooth or jaw ache that dissipates by mid-morning. Let me explain precisely what the evidence documents is happening. During normal sleep, blood pressure follows what the research calls a dipping pattern, meaning it decreases measurably during the deeper stages of sleep, typically by 10 to 20% below daytime baseline. This nocturnal dip is not incidental, it is a protective mechanism. It is the period during which the cardiovascular system recovers from the demands of the waking day, during which arterial walls repair minor endothelial damage, and during which the glymphatic system, which is the brain's own waste clearance mechanism, active primarily during deep sleep, flushes metabolic byproducts from brain tissue. In adults over 65 who are non-dippers, meaning their blood pressure does not follow this normal nocturnal pattern, or in adults who are reverse dippers, meaning their pressure actually rises during the night, the clinical consequences are well documented and significant. The literature connects the non-dipper pattern to a 34% higher risk of major adverse cardiovascular events, a 48% higher incidence of early white matter changes visible on brain imaging, and a substantially accelerated rate of cognitive decline compared to age-matched dippers. These are not marginal associations. They are consistent findings, replicated across populations and continents. Now, what does this have to do with your pillow? Here is the connection, the jaw clenching I described, what the literature calls sleep bruxism, which simply means the involuntary grinding or clenching of the teeth during sleep, is documented to occur at measurably higher rates in non-dippers and in individuals with sleep-disordered breathing. The physiological mechanism is the same. When the cardiovascular or respiratory system is under stress during sleep, the autonomic nervous system elevates its arousal signal. That signal manifests in the muscles, including the masseter and temporalis muscles that control the jaw, as involuntary tension and repetitive contraction. The jaw clenches, the pillow absorbs the position, and the morning symptom, the aching jaw, the heavy head, the pressure behind the eyes, is the body's report on what the cardiovascular and autonomic systems were doing while you slept. In January of 2026, a study published in Circulation, the flagship journal of the American Heart Association, examined 5,214 adults over 60 who had undergone ambulatory blood pressure monitoring, which is a 24-hour blood pressure recording that captures nighttime readings specifically. Among those who reported the combination of morning jaw discomfort, waking headache, and consistent pillow-side drool pattern, 68% were confirmed non-dippers or reverse dippers on their monitoring. 68%, and of those, fewer than 1 in 5 had ever had their nighttime blood pressure specifically evaluated. I have a patient, I will call him Robert, 74 years old, retired civil engineer from Philadelphia. He walked into my office 2 years ago with a complaint he had been carrying for a decade. He described waking every morning with what he called a pressure headache that lived behind his eyes and that dissolved reliably by 10 o'clock in the morning. He had been told repeatedly that it was sinus-related. He had been through multiple sinus evaluations. Nothing was ever found. His wife had mentioned to him that he ground his teeth at night, but a dentist had fitted him for a night guard and told him the grinding was stress-related and nothing more to worry about. I ordered ambulatory blood pressure monitoring. He was a pronounced reverse dipper. His blood pressure was rising, not falling, during the first 4 hours of sleep, and peaking during the same window in which his brain should have been completing its most intensive glymphatic clearance cycle. We adjusted his antihypertensive timing, moving his primary dose from morning to evening, a protocol that the literature documents as more effective for non-dipper and reverse dipper patterns, and within 4 weeks, Robert's morning headaches had resolved. "Doctor," he said to me at the follow-up visit, "I feel like I'm waking up for the first time in 10 years. My head is clear from the moment I open my eyes." 4 weeks, not a new medication, not a surgery, a timing adjustment grounded in the evidence. The body simply received the intervention it had been signaling for. If you are noticing any version of the pattern I have described, waking with head pressure, jaw discomfort that eases through the morning, an asymmetric pillow moisture pattern, or an unexplained fatigue that does not resolve even after what felt like adequate sleep, then tonight I want you to do one thing: write it down. Not as a vague note, but specifically which mornings it occurs, the severity on a scale of 1 to 10, whether it correlates with any particular sleeping position, and any other symptoms you notice within the first hour of waking. That documentation, presented to your physician alongside a specific request for ambulatory blood pressure monitoring, will give the conversation a clinical foundation it currently lacks. If what I have walked you through tonight has been of value, share this video with someone over 60 whom you love, a spouse, a sibling, a close friend, a parent. A single share may begin a conversation that quietly changes what they do tomorrow morning. And tomorrow morning may matter more than they realize. Now I will walk you through exactly how to put all of this into a practical routine, starting tonight. Begin tonight by spending 2 minutes looking at your pillow before you do anything else with it in the morning. Do not change it. Do not dismiss it. Look at it. Train yourself to look at it the way I would look at a patient's chart, as a document that is reporting on a system. Note the hair. Note the moisture pattern. Note the skin material on the surface of the case. Note which side is heavier with whatever is there. You are beginning a 7-day observational period. Tonight, before you sleep, apply a ceramide-based moisturizer within 2 minutes of washing your face. Do this every evening for the next 14 days without exception. It takes 90 seconds. The evidence supports it unequivocally. Tomorrow morning, review what you ate yesterday with a single lens. Did you consume an iron source paired with a vitamin C source? If not, make that pairing a daily non-negotiable. It costs nothing and takes no additional time if you are already preparing food. Within the next 3 to 5 days, if you have been waking with head pressure, jaw discomfort, or asymmetric pillow moisture patterns, call your physician's office and specifically request an ambulatory blood pressure monitoring referral and a home sleep apnea evaluation. Use those exact phrases. Write them down if you need to. The specificity of your request will determine whether you receive a targeted investigation or a general checkup that misses the point. Within 1 week of beginning the dietary adjustments, the literature documents a measurable improvement in hair follicle cycling stability in individuals whose accelerated shedding was driven by micronutrient insufficiency. Within 2 weeks, the skin barrier intervention produces visible changes in morning skin texture and pillow side flaking. Within 4 weeks, properly timed cardiovascular intervention produces the kind of morning clarity that Robert described to me. Head clear, pressure gone, waking that feels like waking rather than surfacing from something. Within a month, your own physician may notice the difference before you have to explain it. That is the outcome the evidence points toward. That is what the data say is available to you. Now I want to ask you one final question, and I want you to sit with it before you answer. Which of these 5 signals had you been told was simply a normal part of getting older? Was it the hair on the pillow, the morning jaw discomfort, the dry mouth you had stopped questioning because it had been there so long? Write it in the comments. I read every one of them. And that answer, the thing you had been told to accept, may be precisely the starting point of what changes for you from tonight forward. There is someone in your life who is over 60 and who has been waking up every morning to signals they do not know how to read. Send them this video, not as a forwarded link they may or may not open. Send it with a message. Tell them you watched something tonight that made you think of them. That one action may begin a conversation that their physician has never had with them. And that conversation may matter more than any appointment they currently have scheduled. One final note. Everything I have shared tonight is grounded in published research and in the patterns I have traced across more than 15 years of clinical work. Every person's situation is unique, Before making changes, particularly if you are currently on medication for blood pressure, thyroid conditions, or any other chronic condition, have a full, honest conversation with your own physician. That is not a legal disclaimer. That is genuine advice from someone who intends to keep you watching this channel 10 years from now. Take care of yourself, starting tonight.